Hi everyone, it's 1 o'clock. We're going to go ahead and get started. We'd like to welcome you to today's webinar on ACSM's updated recommendations for exercise pre-participation health screening. Before we get started, just a few housekeeping things. We will try to get to any questions participants have at the end of the presentation. If you have a question, please type it into the question area within the Go-To navigation. If there are questions we do not have time to answer, we will provide those answers in a frequently asked questions document on our Exercise Pre-Participation Health Screening Resources webpage. An email which will contain a link to that page, as well as the link to the recorded version of today's webinar, will be available and distributed to all webinar registrants and participants later this week. Now I'd like to turn it over to our moderator, ACSM Fellow and ACSM Immediate Past President, Dr. Carol Ewing Garber. Dr. Garber is Professor and Chair, Biobehavioral Sciences at Teachers College at Columbia University. Over to you, Carol.
Thank you, Katie. As the Immediate Past President of ACSM, it is my pleasure to welcome you to this webinar on ACSM's updated recommendations for exercise pre-participation screening. This session will provide an overview of the background and rationale for these new recommendations and explain the new recommendations, and will provide you, as Katie mentioned, some time for you to ask questions. We have two expert speakers today, Dr. Linda Pescatello and Dr. Deb Riebe. Dr. Linda Pescatello is a distinguished professor in kinesiology at the University of Connecticut. She holds joint appointments in the departments of Allied Health Sciences, Nutritional Sciences, and Physiology and Neurobiology at the University of Connecticut, and in the Department of Community Medicine and Healthcare at the University of Connecticut School of Medicine. Her research focuses on three areas: the genetic and clinical determinants of the response of health fitness phenotypes to exercise, particularly blood pressure. Second, the effects of cholesterol medication on blood pressure and exercise performance. And third, physical activity and contingency management as interventions to curb hazardous drinking among college students and enhanced treatment among populations with overweight and obesity and HIV-positive substance abusers. Dr. Pescatello is an ACSM Citation Award recipient, was an associate editor of ACSM Guidelines for Exercise Testing and Prescription, the 8th edition, and senior editor of ACSM's Guidelines for Exercise Testing and Prescription, the 9th edition, and most recently an expert panel and writing team member of a recent update to ACSM's Exercise Pre-Participation Health Screening Recommendations, which is the topic of this webinar. She has served as an American College of Sports Medicine Vice President of Basic and Allied Science, Chair of the ACSM Pronouncements Committee, and as a member of the ACSM Board of Trustees and Administrative Council. She presently serves as a member of the Evidence-Based Committee. Dr. Pescatello is also a past president of the New England chapter of ACSM and serves on their Board of Trustees. Our second speaker this afternoon is Dr. Deb Riebe. Dr. Riebe obtained a Bachelor of Science degree from Springfield College, a Master's of Science degree from the University of Rhode Island, and the Ph.D. from the University of Connecticut. She is currently Professor and Chair of the Department of Kinesiology at the University of Rhode Island. Dr. Riebe is a Fellow of the American College of Sports Medicine, and she served as the President of the New England chapter of ACSM, and she is a recipient of their Honor Award. She served as the Chair of ACSM's Committee for Certification and Registry Boards, and is a member of the Board of Trustees representing Education and Allied Health. Dr. Riebe is serving as the senior editor of the 10th edition, of ACSM's guidelines for exercise testing and prescription, and she was an associate editor of the 9th edition of the guidelines. She chaired the expert panel and writing group of the recent update to the ACSM's pre-participation screening recommendations. She has received research funding in areas of weight management and physical activity promotion from the American Cancer Society, the National Institutes of Health, and the Champlain Foundations. Dr. Riebe has authored over 60 refereed articles and book chapters. So I will now turn over the podium to Dr. Pescatello.
Well, Dr. Garber, thank you very much for that nice introduction, and I'd like to thank Katie for organizing this webinar. And our webinar today will be organized as follows. I will start our discussions with the current ACSM exercise pre-participation health screening recommendations as they are described in the 9th edition of the Guidelines for Exercise Testing and Prescription. Our second item of discussion will be the new ACSM exercise pre-participation health screening recommendations as they were published recently in Med Science, Sport and Exercise, and you see the reference here. And they also will be coming out in the 10th edition of the guidelines that Dr. Riebe is a senior editor on in 2017. And I will start this discussion by giving a rationale for the new recommendations that then will be continued by Dr. Riebe, and then she will share with you actually what the new recommendations are. And then Dr. Riebe will conclude the content of our webinar by applying the new recommendations to a case study. So the purpose of ACSM's our current exercise pre-participation health screening is to identify individuals who may be at risk for serious acute exercise-related cardiovascular events that can include sudden cardiac death and myocardial infarction. And with this purpose in mind, we must acknowledge that vigorous intensity exercise does have a small but measurable acute risk of cardiovascular disease complications, and that it is important to mitigate this risk in susceptible individuals. So we will move on to now what are the current recommendations. And the initial step is that all people wanting to initiate a physical activity program should be screened at minimum by a self-guided medical history or health risk appraisal questionnaire such as the PAR-Q or the Modified American Heart Association ACSM Health Fitness Facility Pre-Participation Screening Questionnaire, both of which are in the 9th edition of the guidelines, for the presence of risk factors for these diseases, as well as other conditions that may require special attention when designing the exercise prescription. And ACSM's current recommendations classify individuals as low, moderate, or high risk based on the presence or absence of cardiovascular disease risk factors, signs and symptoms of cardiovascular, pulmonary, renal, or metabolic disease, and also if there is known cardiovascular, pulmonary, renal, or metabolic disease. Now, in the 9th edition of the guidelines, you see here Table 2.2, which contains the cardiovascular disease risk factors. I won't read the specific criteria because you can review those in your guidelines, but as you can see, the positive risk factors are age, family history, cigarette smoking, sedentary lifestyle, obesity, hypertension, dyslipidemia, and prediabetes. And then the negative risk factor, which can be subtracted from the positive risk factors for the total number, is high-density lipoprotein cholesterol. Now, based on this classification of risk, there is a very important figure in the 9th edition of the guidelines, figure 2.3, which is the logic model for classification of risk. And you start with a review of a medical history questionnaire to determine if an individual has known disease. And as you see here, if they do, they are classified as high risk. If they don't have known disease, but exhibit major signs or symptoms suggestive of disease, they too would be classified as high risk. If there are no signs or symptoms, then you base the risk classification on the number of risk factors. If a person has 2 or more, they are classified as moderate risk, and if they have less than 2, 0 or 1, they are classified as low risk. Then based on this risk classification, what you see here again is another logic diagram that determines whether an individual, based on their level of risk classification, needs a medical exam, an exercise test, or physician supervision of that exercise test. And what you will note from this logic diagram, if you are at low risk, the answer to every single one of these questions is no. If you are at high risk, the answer to every single one of these questions is yes. And if we look at the person that would be classified as moderate risk, the only time the answer is yes is if a moderate risk person wishes to engage in vigorous intensity exercise, they would need a medical examination before beginning exercise. So in summary, the current recommendations are that individuals at moderate risk, and they would have 2 or more cardiovascular disease risk factors, should be encouraged to consult with their physician prior to initiating a vigorous intensity physical activity program. However, while medical evaluation is taking place, the majority of these people can begin light to moderate intensity physical activity programs such as walking without consulting their physician. And then individuals at high risk with symptoms or diagnosed disease should consult with their physician prior to initiating a physical activity program of any intensity. And here you see a new table we added to the 9th edition of the guidelines, table 2.3, that profiles those people that would be classified as high risk. So let's move on now to what the current recommendations are for exercise testing in the 9th edition. And the recommendation is that routine exercise testing before initiating a vigorous intensity physical activity program is recommended, as you saw in those logic models I just shared with you, only for individuals at high risk of exercise-related complications. And what I'd like to share with you now is the rationale for those current recommendations we made in the 9th edition of the guidelines. What we attempted to do was more strongly support the public health message that all people should adapt a physically active lifestyle. We tried to reduce the emphasis on the need for a medical examination in healthy asymptomatic people. We tried to emphasize identifying those with known disease because they are the people at greatest risk for an exercise-related cardiac event. And last, we tried to simplify the process, for we felt that making the recommendations overly restrictive would deter people from exercising, when in fact the greatest risk is conferred by not exercising at all. So keeping these considerations in mind, why would we approximately a year and a half after the 9th edition was published, consider reevaluating what the current recommendations are. Well, we acknowledged that exercise is safe for most people and has many health fitness benefits. The cardiovascular risks associated with exercise lessen as individuals become more physically fit. Exercise-related cardiovascular events are rare and are often preceded by warning signs and symptoms. And last, we felt that the current pre-screening algorithms can result in excessive referrals to physicians for medical clearance, which, as I already alluded to, can be a potential barrier to adopting exercise. And it also can incur added expense on both the individual and our healthcare system. So what we then did in June of 2014, there was an expert panel that was invited to come to the national office in Indianapolis. And you can see the members of this panel on the right. And they were experts in risk assessment, preventive cardiology, public health, exercise physiology and geriatrics, and/or they were practitioners from the field of medicine, clinical exercise physiology, and health, fitness, and prevention. So again, these were the fundamental principles that led to this reevaluation of the recommendation that I reviewed with you a moment ago. And what I'd now like to start with is a discussion about the first, that exercise is safe for most people and has many health fitness benefits. Here you see actually a classic table that is in the 9th edition of the guidelines. And what it depicts is the relative risk of engaging in a bout of vigorous intensity exercise as compared to being sedentary. And as you see here, approximately within 15 to 20 minutes of that bout, with these endpoints that you see here. And if you look at the summary of the relative risk of acute vigorous intensity compared to being sedentary, you can indeed see that the risk of incurring an acute cardiac event is increased anywhere from 2 upwards to 56 times. However, when you put the relative risk in absolute risk perspective, as you can see from this table, the absolute risk of a cardiac event following acute vigorous intensity exercise is very low. Here you see in healthy people and even people with documented cardiac disease that are in cardiac rehabilitation programs, the risk is very low. So in summary, exercise is safe. The relative risk of an event is increased indeed during vigorous intensity exercise compared to rest. But if you look at that absolute risk, it is very low. So let's move on to the second rationale, which is cardiovascular risks associated with exercise lessen as individuals become more physically active and physically fit. And what you see here is, again, a figure in the 9th edition of the guideline with the relative risk of onset of MI on the y-axis and the frequency of heavy physical exertion per week on the x-axis. And as you go from being sedentary to exercising vigorously 5 or more days per week, you can see the significant reduction in risk that almost begins to equate to what the risk would be as we're sitting here watching this webinar. And in fact, what you see at 0 is a risk that exceeds 100, and it gets down to about a little bit over 2. So significant reduction in risk as we become more physically active. This was a recent systematic review and meta-analysis published on the association of irregular physical activity and the triggering of acute cardiac events. And what these authors concluded is that acute cardiac events were significantly associated with irregular physical activity. However, this association was significantly attenuated among persons with high levels of habitual physical activity. And I really think these meta-regression graphs taken from their article says it all. Again, you see the relative risk of myocardial infarction here and sudden cardiac death here compared to the number of bouts of habitual physical activity or times per week. And you can see that as we become more active, going from none to 6, the relative risk of incurring a myocardial infarction is actually decreased 47%. And when you look at this graph, the relative risk of a sudden cardiac death is decreased 30% when you compare, again, not being active to high levels of physical activity per week. So now for the third rationale for the reevaluation of the current recommendations, I will turn the microphone over to Dr. Riebe, who will conduct the remaining portion of our webinar.
Thanks so much, Linda, for a nice presentation, and we'll look forward to Deb continuing.
I'm just having a little issue here. It worked before, and I'm not really sure why the screen's not coming up.
We love technology, but it doesn't always work as smoothly.
Here we go.
So here we go. So here is Dr. Riebe.
Thank you very much. So taking over about why we decided to reevaluate the current recommendations is that, in reality, exercise-related cardiovascular events are actually rare, and very often they're preceded by warning signs and symptoms. Now, this table here is just a table that shows some of the warning signs that individuals will actually experience prior to having an exercise-related event, and I'm sure these are things that you are all familiar with. And again, because there are often signs and symptoms, it would be important for exercise professionals to actually promote education about what to look for, so that if people experience these, that they might be able to, if you will, head it off at the pass and not experience an exercise-related complication. And then finally, when we really took a look at the current guidelines, what we found is that they may result in excessive referrals to physicians for medical exams and exercise tests. And again, we're afraid that this could be a barrier to adopting exercise, which is the last thing that we want to do. And of course, it can be a financial burden to the individual, whether there be a copay or paying for an appointment with a physician, and certainly a burden on the healthcare system. This is a paper that came out in 2014, and this was a very, very important paper from Jeff Whitfield and his colleagues. And what they did is they took the NHANES data and they evaluated it using the ACSM pre-screening guidelines. And what they found, and these individuals in this particular study, they were all age 40 and over. But again, when they took data from, and the NHANES data is a national sample of individuals from all over the United States, what they found is, using our own guidelines, that more than 90% of both men and women would actually have to see a physician prior to engaging in exercise using the ACSM guidelines. And again, that really showed us that we may be putting barriers up to engaging in exercise when in fact it is actually quite safe. When we looked at when you delve a little deeper into the paper, what we find is that it's the high prevalence of cardiovascular risk factors, which is the thing that was having most people be referred to a physician. Having cardiovascular risk factors, and Dr. Pescatello went over the risk factors a little bit earlier, what you found is you saw the list, they're actually very common. And again, that was what was driving most people using our current guidelines to have to go see their physician. And when we really took a look at risk factors very common, yet exercise-related cardiovascular death or exercise-related myocardial infarction is quite rare. So we don't think that the risk factors are really doing their job. They really weren't pointing to who was at risk for having an adverse event during exercise. And again, if you look at some of the numbers that we have here, it helps to illustrate that. You have 65 million people in the U.S. that have hypertension, and 71 million people in the U.S. have high LDLs or low-density lipoprotein cholesterol. So very, very high numbers, yet each year only 600 people in the U.S. die from heart disease, and a very, very small percentage of those happen during exercise. So again, pointing to the fact that cardiovascular risk factors don't do a good job at predicting who is going to have an exercise-related event. So now, I'd like to present to you what the new recommendations are for pre-participation health screening guidelines. Again, the expert panel continued to encourage screening. That it still should be done for everyone that wants to either initiate exercise or progress, particularly to vigorous physical activity programs. Again, the expert panel continued to recognize that vigorous intensity exercise does have a small but measurable increased risk of cardiovascular complications during exercise, and that it is important to identify those individuals who may be susceptible to this. And again, the expert panel still wants exercise professionals to consult with their healthcare providers anytime there's a question about individuals that have known disease or they have signs and symptoms of disease, or really if there's any other concern that the exercise professional might have about the safety of exercise participation for any individual. And in fact, an important statement that we wanted to get across was that these are simply recommendations, and they are not a replacement for sound clinical judgment. And exercise professionals should always make the decisions on an individual basis and refer to a healthcare provider if they think they should. That being said, the new pre-participation screening recommendations are quite different. And it does take a little while to get used to it because we've done it the other way for a long time. Now, we are asking exercise professionals to look at three things: to look at the individual's current level of physical activity, to look at the presence of signs and symptoms or of known cardiovascular, metabolic, and renal disease, and then also to consider the exercise intensity in which the participant intends to participate. What is different? We're no longer including a cardiovascular disease risk profile as part of the decision-making process for referral to a healthcare provider. So it's important to understand that we still think doing a cardiovascular disease risk profile is very important, and it should be part of what every exercise professional does. However, it is not part of the pre-screening procedure in making decisions about referral to a physician. Because we're not doing that, we're no longer classifying individuals as low, moderate, and high risk. Again, another change is that there's general recommendations for medical clearance, and there are not specific recommendations for medical exams or exercise testing. Those decisions really are made by healthcare providers, not by the exercise professionals, and so we've had a clarification of wording. And then finally, any person with pulmonary disease is not automatically referred for medical clearance in this new procedures. This is what the algorithm looks like, and this is what you can find in that paper that was published in MSSC back in November. It is very detailed. Sometimes the columns look very similar, but we kept it this way because it is so new and we think it's easier to follow, particularly because there is such a big change. So the first question that's asked to a person is, do you participate in regular exercise? And regular exercise is defined as participating in exercise at least 30 minutes, 3 days a week for the last 3 months. And then based on the participation in exercise, it's either no, and you go to the left-hand side of the algorithm, or the answer is yes, and you go to the right-hand side. Now what I have done here is I've broken it up so it's a little bit easier to see. So here are the people that do not participate in regular exercise. So once we know that they don't participate, if we go to the first column here on the left, no cardiovascular, metabolic disease or renal disease, and no signs and symptoms suggestive of these diseases, medical clearance is not necessary, but we do recommend light to moderate intensity exercise, gradually progressing to vigorous if that's their desire, following the guidelines. If the person has disease, even if they're asymptomatic, if they are not exercising, we are recommending medical clearance. And again, following medical clearance, they can participate in exercise, again recommending they start with light to moderate intensity. And then finally, if a person has any signs or symptoms that suggest disease, even if they have not been diagnosed, we are recommending medical clearance. And again, if they receive medical clearance, starting with light to moderate intensity activity. If a person has been participating in regular exercise and hence are at lower risk, here are the new recommendations. Again, if they don't have disease and they don't have signs and symptoms of disease, medical clearance is not necessary. And again, because these individuals are already exercising, they can continue with their moderate or vigorous exercise, and they can progress as wished. If the individual has known cardiovascular, metabolic, or renal disease, but they're asymptomatic, medical clearance is not necessary if they're doing moderate intensity exercise. If they desire to engage in vigorous intensity exercise, we are recommending they get medical clearance. However, the medical clearance can be within the last 12 months as long as there's been no changes in signs and symptoms of disease. So in other words, if I saw my physician a couple of months ago and that physician gave me clearance to exercise, and I've just recently decided to move to vigorous, but my physician said it was okay a couple months ago, I don't have to go back again. We don't want that to be a barrier. And then finally, if there's any signs or symptoms that suggest cardiovascular, metabolic, or renal disease, we would actually recommend that the person, remember this is an active person, we would recommend that they discontinue exercise immediately and they actually seek medical clearance. And again, once they get the medical clearance, they can, and if everything's okay, they certainly can return to their exercise program. Again, the word medical clearance has replaced specific recommendations for having a medical exam or a medical test. Medical clearance is defined as the approval from a healthcare provider to engage in exercise. And again, if it's someone that regularly sees their physician, a physician has the choice to give them medical clearance without having another appointment. Again, reducing the barriers. If it's someone that hasn't seen their physician for a while, the physician may require them to come in, and will decide to what extent to have the medical exam or any type of exercise testing. And by exercise testing, we're talking about ECG stress testing. The reality is there's really a lack of evidence that exercise testing is effective in mitigating the risk of adverse exercise-related cardiovascular events. Some of the current guidelines that are out there, here's some guidelines, a paper that was in JAMA, And again, these specifically looking at older adults, individuals that are over 75 years old who are interested in starting a program. Again, from the paper, it says in addition to being expensive and of unproven benefit, the current policy of routine exercise testing could potentially deter many older persons from participating in an exercise program. These are some guidelines from the U.S. Preventive Services Task Force, and this is a paper from 2004. There is another paper from 2014, and again, the U.S. Preventive Task Force has said that exercise testing has no value in low-risk asymptomatic adults, and at this point, there is insufficient evidence for or against testing subjects at higher risk. So in other words, there's not enough data out there to make these decisions. And then finally, a paper from the American Heart Association, again, that randomized clinical data on the clinical value of screening testing are absent. It's simply not known whether routine exercise testing reduces the risk for premature mortality or not. So the data really aren't there to routinely require medical tests. Again, these are decisions better made by the healthcare provider. So we've done this, and now looking at a little bit of a case study to contrast the current recommendations that are in guidelines and these new recommendations that were published a couple of months ago. So this is a real person. It's Louise. She's 55 years old. She's a corporate executive, 5'6". She weighs 145 pounds with a BMI of 24. Does not smoke. Her father has a history of MI at age 74, and her mother and one of her sisters has type 2 diabetes. Looking at some of her risk factors, her blood pressure is 128/84. Her total cholesterol is 218, LDL cholesterol 141, HDL 52, and she has a fasting glucose of 122. She reports no signs and symptoms of chronic disease and no diagnosed cardiovascular, metabolic, or renal disease. Louise has walked 4 to 5 days a week for years. She recently got a job promotion. She doesn't have as much time. She'd like to join her fitness center at work and potentially walk at lunch, or maybe doing something a little more vigorous in the fitness center. Again, using the old guidelines, you will use most of this information. Using the new recommendations, you really only need what's underlined. So again, the current guidelines that are in the 9th edition of the guidelines. Again, she has 3 risk factors: age, dyslipidemia, and prediabetes. She does not have any signs or symptoms. She has no known disease. Based on the risk factors, she's at moderate risk. So she would not need to have a medical exam if she were going to do moderate intensity exercise. However, if she were going to do vigorous intensity exercise, she would need to have a medical exam before engaging in that exercise. For this person, an exercise test would not be needed. Using the new screening guidelines, there's fewer questions that you address. She does participate in regular exercise. Again, she has no signs and symptoms and no known disease. She would not need medical clearance if she was going to participate in moderate exercise. And she would also not need medical clearance if she were going to participate in vigorous exercise. So you can see, and this is actually someone that Dr. Pescatello knows, and you can see how the new recommendations have potentially decreased the barrier to, in this case, her progressing to more vigorous exercise. So again, I think these new recommendations out there has continued the work that Dr. Pescatello did in the 9th edition of guidelines, in continuing to emphasize the public health message for regular physical activity for all, and continuing to simplify the pre-screening process with having fewer people needing medical clearance or exercise testing prior to exercise, especially when it's low We also, at the roundtable, talked a little bit about the fact that there are other things that exercise professionals can do to decrease the likelihood of an exercise-related cardiovascular event. And that's really paying attention to some of the things that we have listed on this particular slide. First and foremost, the exercise prescription. Again, there's the little saying, start low and go slow. Again, paying attention to the frequency, intensity, particularly of exercise, and also the rest of the prescription. And again, having the progression slow, having a nice transitional phase where you start with low to moderate intensity physical activity and gradually progress can do a lot in helping to prevent events. Certainly using a warm-up and a cool-down with exercise. Again, very often, exercise-related events are preceded by signs and symptoms. If we could do more to educate people as to what to look for, so if they have any of these signs and symptoms that are maybe a little more subtle, they pick up on them. Again, it is people who are physically inactive that are most likely to have an exercise-related event. If we could get the most inactive people, even just walking, and move them out of that really physically inactive cohort, we would do a lot to prevent exercise-related events. And of course, anybody who is physically inactive should not participate in unaccustomed, vigorous intensity physical activity. That is where we see most of the events. Again, the start low and go slow. So the publications that are upcoming that will present this, as Dr. Pescatello mentioned at the beginning, the new recommendations were published in the November issue of Medicine and Science in Sports and Exercise, and then they'll be presented in certainly greater detail when the new edition of guidelines comes out in 2017. So at this point, I'm going to turn it back to Dr. Garber, and we'll be ready to take some questions and answers.
Great. Thank you, Dr. Riebe, and thank you, Dr. Pescatello and Dr. Riebe, for a wonderful, informative talk. And I'm sure everyone on this webinar has learned as much as I have this afternoon. We now have an opportunity for some questions from the audience. So if you have a question, you can go ahead and type it into the question area on your screen, and we will direct your question to one of the presenters. I already have a question from the audience. I'm planning to take the ACSM certification in the fall. Does that mean I have to start studying all over again to include these new updated recommendations? Well, I'll answer that question. If you're taking the exam before 2017, this new information is not going to affect you. So you don't have to panic. You don't have to go and start studying all over again. The content that's in the current exams, as well as in all the preparatory materials and workshops, won't include this update at this time. The new exam changes, which will include the new pre-participation health screening, will be incorporated in the new exams in the new exam release in June of 2017. ACSM does major updates to exam content every 4 years, and so that's not going to change in this case. So prior to that date, and you'll hear an announcement about this, you can continue to use your current 9th edition of the guidelines and your study materials to prepare for the exam. And good luck with your test. I have another question, and this question is directed towards Dr. Riebe. You did a really nice job explaining, but I'm still kind of confused between the difference between medical clearance versus a medical exam or an exercise test, and how that works. Can you help me understand this a little bit better, Dr. Riebe?
Sure, I'd be happy to. So medical clearance is basically a doctor advises a patient that it's okay to exercise. Now, in the past, we have made very specific recommendations for a person needing a medical exam and or an exercise test. And again, our definition here of an exercise test is basically an exercise stress test with ECG. And again, that was based on having disease, having signs and symptoms, but also based on cardiovascular disease risk factors. And then again, based on those things, these individuals were classified as low, moderate, or high risk, and they were recommended to have a medical exam and or an exercise test based on that information. Again, now we've simplified it. It's medical clearance. We're leaving the decision up to the physician as to the amount of evaluation a person needs prior to engaging in exercise. It may simply be that the physician reviews a patient's chart and deems them fine to initiate an exercise program without even seeing them. And again, we leave that decision up to the medical provider, reducing a barrier. We also know that there really isn't a lot of evidence that says medical exams or exercise testings will be effective in mitigating the risks of exercise-related adverse events. So hopefully we've decreased barriers, yet we're still in touch with medical providers when necessary.
Great, thank you, Dr. Riebe. Keep your questions coming in. I see many of you do have questions, and we will get to them during the webinar, or if we cannot, we will get to them later, but we will give you an answer, so please ask your questions. This next question that's come in is for Dr. Pescatello. So how do these new pre-participation recommendations affect my job if I'm working directly with clients on exercise programming?
Great question. The new recommendations will change how you go about determining whether or not your client needs a referral to a healthcare provider prior to commencing an exercise program. Now, remember, the three items to consider in determining if medical clearance is needed would be the current physical activity level of the person, whether they are exhibiting signs and symptoms of certain diseases, and also the exercise intensity they would like to exercise at. One thing that Dr. Riebe stated on several occasions during her portion of our webinar is it's important not to forget that the new exercise pre-participation health screening recommendations are not a replacement for our sound clinical judgment, and decisions about referral to a healthcare provider for medical clearance prior to the initiation of an exercise program should continue to be made on an individual basis. And again, I refer you to that algorithm that Dr. Riebe walked us all through during her portion of our webinar.
Thank you, Dr. Pescatello. The next question I'll direct to Dr. Riebe. When should I integrate the recommendations of the new paper and the upcoming guidelines for exercise testing and prescription into my exercise professional practice?
Well, the consensus statement has been published. You actually can incorporate the new recommendations now. And of course, when the new guidelines comes out in 2017, there'll be more detail that might be helpful. I might also mention that for exercise professionals that this summer in the Health Fitness Journal, there'll be a new tool coming out, kind of a tool that health fitness professionals can use to actually help you go through the recommendations, go through the actual process of the pre-screening. So hopefully that will be very helpful, and that will be this summer.
Great, thank you. Next question that's coming in over the line. I'll direct to Dr. Pescatello for this one. Do the changes in liability affect me when working with my clients in any way?
Well, the good news is, again, when any of us deal with change, we're hesitant to implement it. But in this case, with the implementation of the new guidelines that Dr. Riebe just said can take effect immediately in your facilities, the liability for fitness professionals who rely on these recommendations has not changed. Fitness professionals must continue to use reasonable care in training a client. As has been the case, there is recognition that there is some assumption of risk with regard to fitness training under the guidance of a fitness professional, as there always has been, and waivers and releases can limit future liability. As we have stated both in the paper that was published in MSSC in November and our webinar, the new exercise pre-participation health screening recommendations are not a replacement for our sound clinical judgments. And decisions about referral to a healthcare provider for medical clearance prior to the initiation of an exercise program, as I stated earlier, should continue to be made on an individual basis.
Great, thank you. Hopefully that clarified your question. The next question that we have, I'll send along to Dr. Riebe. And this question is, what's the impact on me as a faculty member? Do I need to change what I'm teaching if my students are preparing to take an ACSM certification exam?
That's a very good question. We actually encourage you to teach the new recommendations. The caveat to that is if your students are preparing to take an ACSM certification, the content won't be incorporated into the exams until June of 2017. So perhaps something that you can do, and what I did with my classes, is show them the old recommendations and the new recommendations, and again told my students that really to use the new ones, but made them aware of how the changes, and perhaps you can even use content from this webinar, to have them understand why the rationale for the changes. But again, we really encourage you to teach the new recommendations.
Great, thank you. I have a question which I think I will actually call on Dr. Riebe again for the answer to this one. And the question is, will there be anyone speaking at the Health Fitness Summit meeting in the spring about these new guidelines, and could this be part of the exercises medicine session that will be there at the summit?
We're going to have some type of event at the Health Fitness Summit. I don't think it's going to be a formal presentation. It might be a little informal, where individuals can come up and ask questions. We know that sometimes it's difficult to understand when this new information, we've done it one way for so long. So ACSM is still working on exactly what that's going to look like, but there will be something there which really will allow you to ask a lot of questions and really kind of get into the meat of these new recommendations. So I guess stay tuned, and we'll what exactly the format that we're going to present this in.
Great. So I would just recommend that anyone who will be attending the ACSM Summit, which I certainly encourage you to do, it's a wonderful meeting, that you just stand by and you'll get more information about opportunities to update and learn more about these recommendations. Moving on to a next question, one of our participants is wanting to know, who is the healthcare provider who will provide the clearance Perhaps Dr. Pescatello or Dr. Riebe, would you be able to clarify? Is that a physician, or are we talking about physical therapists or other professionals?
Dr. Riebe?
I don't know, either Dr. Pescatello or Dr. Riebe. I'm not sure who would like to answer that one. Who would be the healthcare professional for who could provide the clearance for participants?
I think in most cases it will be a physician. What I think we see is that healthcare is changing quickly, and there are other healthcare providers, nurse practitioners, and so forth. So I think that's something that we'll have to keep our eye on as we move forward. I do think right now, in most cases, it will be the physician, but open up to other changes in the healthcare system as it moves forward. I don't know, Dr. Pescatello, do you have anything to add there?
It's funny because the webinar participants don't realize it, but as your questions come across, they're visible to us. And I saw that question come up, and I thought it was excellent. And in the panel, Dr. Riebe, I think we talked about this briefly. I will say I think the assumption made of the expert panel at the time is that it would be a physician, but again, as these guidelines get implemented in clinical practice, and it happens with the 9th edition of the guidelines, the 10th edition of the guidelines, and even these new recommendations, there's just certain things that crop up that at the time we didn't think about. So I think as they get implemented and we continue to get feedback, maybe at some point in time in the future, we better specify who those healthcare professionals are. But I would say that the consensus is what Dr. Riebe verbalized, in that it would be primarily a physician or a physician, as was done with stress testing in the current recommendations, that they would have a designee. And then we also have to be flexible in terms of the healthcare environment continuously changing.
Great. Thanks for your answer. I guess currently it would be based on the license and scope of practice of different health professionals as to who could actually provide that advice at the current time.
Dr. Garber, I would just say in our setting, and again, we're in academia, but we do get subjects that we have to state will go through this process. I can tell you our IRB would clearly indicate that it would have to be physician clearance.
Right. Thanks for saying that. Because actually, someone else had a question here about how these could be implemented in research settings. So it sounds like, have you actually done that at the University of Connecticut?
We have not at present, but I would suspect with any, again, as Dr. Riebe stated, we should be implementing this now as new IRB protocols come forth, that we would be following these guidelines. And again, at the University of Connecticut, its stores, having sat on the IRB, I know the stipulation would be that it would be a physician giving the clearance.
Great. Thank you so much. We have another question here from one of the participants who is asking about pulmonary disease and how that is used to as part of the pre-participation clearance. So they're still not quite clear on how that fits into the logic model. Dr. Riebe, could you address this one?
In the previous recommendations, anyone with pulmonary disease was automatically referred for medical clearance. And that's what has changed. Now when you have an individual with pulmonary disease, they will not be automatically referred for medical clearance because generally speaking, pulmonary disease doesn't increase the risks of cardiovascular complications during exercise. So, and again, that's the reason for pre-screening, is to identify those individuals would have an adverse cardiovascular event. We do caution you, however, that individuals that do have COPD, very often COPD and cardiovascular disease are comorbid because they have common risk factors, especially a risk factor like smoking. So again, that if you have a person come in with COPD to exercise, that you kind of be very careful with these individuals and pay real close attention to the signs and symptoms of cardiovascular and metabolic disease, because again they're so often comorbid. Does that answer the question?
Oh yeah, please go ahead, Dr. Pescatello.
Yeah, and again, and it's been stated several times, adapting to new recommendations when we've been doing things the old way for so long is a challenge for all of us. And I guess I would like to use an example in this regard, because I happen to have asthma, and I have a son who, for a period of time in his life when he was young, had very unstable asthma. Asthma per se, well, pulmonary disease was mentioned in the old guidelines, but something that wasn't mentioned for medical clearance is an acute sickness episode. The way I would look at asthma now is that we have taken it out of the pre-participation health screening recommendations, but nonetheless, if there were to be an acute flare-up, just like with any acute illness, the recommendation would be that you don't exercise, and this person in particular may have to go see a pulmonologist to get his or her asthma under control. But it's not used for the new recommendations per se. And I guess that comes back to that good clinical judgment.
Great, thanks. So really, you're not ignoring asthma, but it's not part of the initial decision making as to whether a person can start exercising or not, as far as needing clearance. But with somebody who has a chronic disease that may be symptomatic that's not mentioned here, those still should not be ignored, and that is part of the practice of the exercise physiologist, right? To check that out and to decide whether it is safe to exercise or not, and whether the person should go to the doctor. Is that accurate?
Yes.
Absolutely. Following pre-screening, we still do a pre-exercise evaluation that is often a medical history, and that's where your cardiovascular risk analysis will be, and you might uncover things not in the pre-screening, but in the pre-exercise evaluation that will still warrant you deciding it would be in the best interest of your client or your patient for them to seek medical clearance.
Thank you. We're just at a little bit beyond the top of the hour, so I think we have time for one more question, which I think I will throw out to either Dr. Pescatello or Dr. Riebe to weigh in. But this is a question from out of the country, from the UK, where medics and physicians don't routinely conduct stress tests and often aren't really willing to provide examination or consultation about exercise. Do you have any advice about how the new guidelines, recommendations for pre-participation might be useful or be applied outside the U.S.? Because I think, as I remember, I don't think that in most cases it requires a specific doctor's visit.
Correct. I would. Again, it's tough with our old mindset, and again, when Dr. Riebe went through her portion of the webinar, what has changed is the need for medical clearance. And it is the person that conducts that would determine whether a stress test is needed. But stress testing per se is not part of the new recommendations. I don't know if that's, the confusion.
Right. Right. I think it's more whether the person, if for the physicians, if they would, they won't see a patient who comes in who just needs to be cleared for exercise. So at least as I recall, some of the conversation, it was that we could, this could occur during a routine visit with a person's physician or medic, so that they could get the clearance while they're seeing the physician or practitioner for another reason. I think I will also make one more mention that there will be upcoming publication that will help provide more guidance for the physician related to these recommendations. So those, we'll look for those. You'll hear some announcements about that through ACSM. I think we've come to the end of our webinar, and I again would like to thank Dr. Pescatello and Dr. Riebe for a wonderful presentation, and thank all of you for participating in the webinar. And I will turn over before we close to Katie Feltman, who has just some final housekeeping items to mention to you.
Thanks so much, Dr. Garber, and thank you, Dr. Riebe and Dr. Pescatello, to all three of you for your work on this topic, as well as taking the time out to help continue to educate everybody about this topic today. So we were overwhelmed in a good way with your questions, which is wonderful, the level of engagement, and some of them are very valuable to everybody in the ecosystem that needs this information. So just as a reminder, and it's probably going to take us a little more than a few days to gather the answer to your questions, but we will get all the questions that were asked today answered, and we will put them in an FAQ format and make sure that everyone who attended today is sent a link that will include that information. So we will get your questions answered. There was another housekeeping question about the PowerPoint from today. We will also make that available to all registrants and participants today, and that will also come in an email link. So again, thanks everyone for your time, and this concludes our webinar for today.